A very good day to everyone. Today we'll briefly talk through about portal hypertension and its potential measurement, briefly touching upon the current published data, talking through on how to assess liver anatomy and finding the hepatic and portal vein branches, as well as sharing an EUS PPG case. As you will already understand, portal hypertension is defined as the gradient of blood pressure between the portal venous system supplying the blood into the liver and the hepatic veins carrying blood away from the liver. Each of these veins will have a pressure, and of course the gradient is the difference between the two of these. The normal pressure gradient is anything less than 5 millimeters mercury. A gradient above 5 millimeters defines portal hypertension. The most common cause of portal hypertension is cirrhosis. Other causes include post-hepatic obstruction of blood flow, for example, right-sided heart failure or hepatic vein thrombosis like Budd-Chiari syndrome, and pre-hepatic obstruction to blood flow, for example, portal vein thrombosis or idiopathic non-cirrhotic portal hypertension. Measuring the portal pressure gradient is a valuable tool, of course. Most commonly in our unit, we obtain portal pressure gradient to assess the risk of liver failure and mortality post-liver resection in patients with compensated chronic liver disease or hepatocellular carcinoma. However, it can also be useful to provide independent prognostic information on survival and risk of decompensation. In addition, the PPG response to pharmacological therapy enables the identification of patients with portal hypertension who are most likely to benefit from treatment. Currently, the most common current method of calculating this pressure is via a transjugular route. This is an indirect method with the gradient known as the hepatic venous pressure gradient, or HVPG. To perform this procedure, an interventional radiologist makes an incision and places a catheter into the internal jugular vein and passes it down via the superior vena cava into the IVC and then into one of three branches of the hepatic vein, usually the right hepatic vein as seen in this example. This pressure is referred to as the free hepatic vein pressure, as you can see in the right image. As it is not possible to access the portal venous system without a second direct percutaneous puncture, the portal vein pressure is measured indirectly by inflating a balloon on the catheter tip to occlude the vein, as seen in the left and middle images here. This is referred to as the wedged hepatic vein pressure measurement. This measurement is a pressure assessment inside the sinusoids. The sinusoids eventually connect to the portal vein, and therefore the wedged hepatic vein pressure indirectly reflects the portal vein pressure. This HVPG methodology is the current gold standard for diagnosing portal hypertension. EUS-guided portosystemic pressure measurements allow both pressures to be measured directly by entering a needle into a hepatic vein and then into the portal vein or a branch of the portal vein. The first human single case of EUS portal pressure measurements was published and reported by Fuji Lau and colleagues in 2014. And then subsequently, Dr. Kenneth Chung's team in California have undertaken some pioneering work with various pressure transducers and needle sizes on animal studies. In 2017, they published a human study of 28 patients showing a 100% technical success rate and no adverse events. In addition, there was current excellent correlation with the current gold standard of the indirect measured using interventional radiology. Currently, there are a number of prospective multi-center trials open both in the US and across the globe, as well as in Europe to obtain broader evidence and consensus. Okay, so let's look at some EUS. Generally, the hepatic veins are seen in longitudinal direction stretching away from the IVC, whereas the left portal vein, the left bile duct, and sometimes the artery will generally be seen in cross-section and then becoming more linear in orientation towards the hilum as we enter the portal vein. In this case, the bile duct is also very dilated and is bigger in diameter than the left portal vein. Usually the bile duct should be smaller than the adjacent portal vein branch and therefore obstruction should be considered. Don't forget, of course, but a bile duct can appear equally as large in diameter after a cholecystectomy or liver transplant. As you rotate, you will view segment 1 and 4 and see the middle hepatic vein. Both the middle and left hepatic veins are good candidates for cannulation. The origin of the right hepatic vein can also usually be seen. However, to cannulate this, one would usually have to cannulate through the IVC. When cannulating, it will always be safer to traverse through as much liver parenchyma as easily possible. This is how radiologists will always consider the liver biopsies, as there is good data which shows that peripheral liver biopsies are more likely to cause post-procedural bleeding than those taken centrally, as there is far less parenchyma to help to tamponade any bleeding. If you remain uncertain, pulse wave Doppler reveals the triphasic waveform of the hepatic venous system, reflective of the transmitted pressure changes of the right atrium, whereas the portal venous system waveform is of course much more constant. Because of breathing movement of the diaphragm and the subsequent movement of the liver, it can be a little tricky to keep your Doppler gate on the targeted vein. Nevertheless, if you're able to appreciate liver anatomy relatively well on EUS, there will be no need to spend time recording Doppler signals. Setting up is straightforward. Inside your Cook Medical EchoTip Insight box is included a small manometer, a connecting catheter together with a 25 gauge FNA needle. Turn on the manometer and connect to the FNA needle using the connecting catheter and flush through with saline, and lock the two-way tap by turning the small side arm to the lateral inlet. Those of you familiar with a 25 gauge will know it does take a little pressure to flush the needle and only a few mils are required. It is really important to make sure there is no air in the system, and of course, once fully flushed, do not remove the saline syringe. You will not usually require more than 10 mils of saline for the entire procedure, including flushing the needle and taking 3 measurements for the hepatic veins and 3 further measurements for a portal vein branch. Use the average of 3 readings for each vessel. Consider how you might standardize the placement of your pressure transducer, which is a critical step. This needs to be at the same level as the heart, and if you do your EUS with a patient in a supine position or in a prone position, you will need to be in the mid-axillary line. In our unit, we tend to do this procedure under conscious sedation with the patient in a prone position, as you can see. We now use a relatively cheap laser level to help create consistency for our levels and measurements. It should be noted that the absolute values for each measurement are less vital, but of course it is very vital to have consistency when doing both sets of readings. It is vital to keep the manometer in a similar place. You can see here by changing the position by a few centimeters, the manometer reading changes from 22 to ultimately 18. Okay, so let's see a case. This is a case of a 70-year-old female patient with a known NASH cirrhosis. On interval imaging surveillance, she was discovered to have a 2 centimeter lesion high posteriorly in segment 7, as you can see here. LFTs are mild to moderately deranged. The multidisciplinary team meeting felt that non-anatomical resection may be a feasible option, and therefore had requested a portal pressure gradient measurement. If we just pause the video here, one can appreciate the background changes reflective of cirrhosis, a heterogeneous nature of the liver parenchyma, and the liver surface irregularity, atrophy in particular around the fissural planes of the ligamentum venosum and ligamentum teres. Before passing the needle, I check that I'm avoiding any significant varices with the gastric submucosa or indeed the subgastric space. I personally aim to minimize the number of hepatic surface punctures to reduce any risks of bleeding, and therefore tend to only take 1 puncture each of the hepatic vein branch and a further puncture of the portal vein branch. Once assessed and in a stable position, the needle should again be flushed with 1 ml of saline, removing any tissue debris or clot. This is a good opportunity to confirm the intravascular position of the needle tip, as flushed saline will be visible. The pressure readings of the manometer first rise when flushing and then will come to settle. and allow 60 seconds for this to happen. Repeat this process in total 3 times to help ensure consistency and use the average reading. In my early experience, very occasionally I've noticed the first reading to be significantly different to other readings, and I wonder if a small piece of tissue may still remain within the needle tip. I'll therefore disregard this reading and take a further 3 readings. You can see patience is important. This reading finally settles at 8. It can be just as easy to puncture the left hepatic vein as seen here in a different case, although I share this to demonstrate that an increasingly fibrotic liver can be slightly tougher to access the vein. Then of course puncture the left portal vein branch or the main portal vein for a further 3 readings. Again, flush the manometer. As you will note, the pressure readings are high and then settle down slowly over the next 60 seconds or so. In this case, you can see the readings are steadily dropping, and 25, and now steadily again dropping down to 24. Remember to have patience and try and wait the full 60 seconds. In this case, it settled at 23. In this particular case, all 3 readings for the left portal vein and the middle hepatic vein were consistent at 23 and 8 respectively. So the portal pressure gradient in this case is 23 minus 8, equaling 15, and significantly higher than that of the normal range, which should be less than 5. Gradients above 10 suggest clinically significant portal hypertension, and above 12 are more likely to cause rupture of varices. Above 16 have an increased mortality risk in general, and above 20 have a high mortality rate, usually secondary to failure of successful treatment of varices during acute bleeding. So in this case, with a pressure gradient of 15, the risk of post-operative decompensation and mortality is high, and alternative treatment means like transarterial chemoembolization was considered as more appropriate. Thank you for taking the time to listen. I hope this has been a helpful sharing of the early experience of using EUS PPG. I know in years to come we will get further data and understanding of its use, but nevertheless it seems very, very promising indeed.